Welcome, bienvenue, karibu to everyone who's joining us for this session of HSR 2020. This is a multimedia session that is looking at how multimedia can contribute to reimagining health systems for more socially and ecologically just future. We're very excited to have you, and you have got 4 fantastic presentations to help us grapple with these issues. But before we start, a few rules, and I mean, what would the world be without rules? So the first is that please participate actively on the live Q&A section. So post your questions there that you can then present to our speakers today immediately after their presentations and at the end of the session overall. Remember to keep your mic and video muted throughout the session, and really do participate as much as you can. So we'll jump right into the first presentation by Dr. Renzo Guinto, who's the Director, Planetary and Global Health Program at St. Luke's Medical Center, College of Medicine in the Philippines. Welcome, Renzo.
What I understand of climate change, the cause is the increasing concentration of greenhouse gases in the atmosphere.
Climate change is nothing more but the effect of the abuse of our environment. Mother Earth is already asking for rent for the space that we are occupying.
Majority ng barangays natin is coastal barangays. So prone po sila, hindi lang po sa bagyo, sa storm surges, at saka sa sea level rise.
Dati malaki pa itong isla at saka maraming tao dito. So ngayon, maliit na ng space namin. Siguro mga ilang metros na sigurong kinain ng dagat.
Idagdag na rin natin po yung saltwater intrusion. Yung mga deep wells nila ay napapasok na po ng saltwater. So hindi na po yun potable.
Wala na kaming matayuan dito ng bahay. Dati may lugar pa kami na matayuan sa gilid ng dagat. Sa ngayon, medyo mataas na. Bali, high rise na kami.
A big majority of people in Ahoy are working in agriculture, farms, fishing. They force themselves to really work under the sun, so they get sick.
The fisherman knows how to predict the weather by just looking at the leaves of the star apple. Unfortunately, it doesn't work right now.
Tapos kung mga tagtuyot, hindi sagana yung na mga tatanim na mga palay.
What guarantee do you have that today, this year, we are going to have a good harvest? Next year, we're going to have a very scarce harvest.
Because of climate change, yung mga seeds natin hindi pa resilient po sa hotter weather at saka intense rainfall.
With increasing population, more demand for environment, resulting to climate change, resulting to problems in health.
Kung tagbaha, maraming sakit na pwedeng lumabas dyan, lalo na pag yung mga tao na sa tubig, like mga leptospirosis or mga skin disease po.
Before the Yolanda, nobody really takes climate change seriously.
Kahit ako, nung time na to, parang hindi ko lubos maisip na mangyayari. Talaga ay yung gano'n, nakala ko sa lang, sa mga pelikula lang.
So we knew it like maybe 10 days or 2 weeks before that there might be a super typhoon coming. We really did not bother to prepare because we did not believe.
Bubong ng aming RHO, natanggal na.
Nung nahupa na yung tubig, marami ng pasyente na pupunta dito, puro mga sugat.
Hindi naman kami maka-refer sa hospital kasi yung daan, hindi naman madaanan kasi maraming kahoy na nakaano sa daan.
Hindi isa kasing pasyente na dito lang dinala, patay na yun eh. Kamayaan yata ng kahoy sa sa ulo. Breadwinner ng pamilya.
I think we are on the right track right now because of our Yolanda experience.
I think we are more prepared.
Handang-handa na po. Dati kasi, yung mga BHW, hindi pa sila masyadong tinitrain kung paano yung mga basic na gagawin, like mga first aid.
Kung climate smart, yung isang health system, yung dapat kailangan i-provide regarding sa health, So dapat andoon na lahat-lahat.
Yung mga bahay po sa island barangays natin, may mga rainwater catchment system sila.
For disaster, we have volunteers. We do drills in the municipal building, in the schools.
So yung mga priority projects po na-identify nila is yung stockpiling po ng goods. So next is equipping po ng ating emergency response, like communications equipment.
If you talk about climate change, it should be the concern of all the agencies. It should be the concern of the whole community. It should be the highest priority of the LGU.
Yung DRR plan po natin, ginawa po yun kasama po ang iba't ibang sectors natin. Yung council natin is made up of all the department heads, especially health, agriculture, DSWD.
In all areas of governance, the people really are the most important.
It's easier kasi pag maintindihan ng community and they're part of it, of implementing the program.
The people are the supreme authority of what they need, of what they plan for their future.
Ang community po mismo ang gagawa ng hazard assessment nila. So ma-identify nila kung anong hazard ng kanilang community at saka sila din po ang mag-identify kung anong solusyon dito.
It should not be a piecemeal approach. It can never work if you are going to approach it in a one-month program or in a two-day seminar. It has to be walked through for the whole year.
Hindi po porket binahaan tayo ngayon, gagawa tayo ng program next year para sa baha. Kundi we look at 5 years from now, 10 years from now, to 25 years from now.
We are a little bit lucky because we have a leadership that is attuned to the times. We are not planting trees for the present generation, but for the next generation.
Last year, we launched Project Happiness with hashtag such a joy to be here. So we want Ahoy to be a better community, a happy community.
Climate change is good politics because whenever you talk about climate change, you are talking about lives of people. You are talking about stomachs of people.
Yung vision ko sa Ahoy is not only magiging victim po yung community natin. They are more than that. They are strong. They can prepare.
We do not have any choice but to confront it and prepare ourselves, prepare our people.
The show must go on.
Renzo, I'll ask you to just switch on your video and unmute yourself. I mean, this is a fantastic video. It's a shame. It's a real shame that not everyone gets to see, the fantastic presentations you sent in. And I'm aware there's a whole suite of work that you've put into, your PhD and other work. And I guess my question to you now is, I mean, we only got to see just, just a piece of the work that you put in with these communities and so on. And I mean, what's the impact of these this using multimedia on the discourse on planetary health in the Philippines and elsewhere?
Thanks so much, Kenneth, for this wonderful opportunity, and glad to be surrounded by amazing colleagues in the health policy and systems research community. Thanks again for showing that that short film that I was privileged to direct and produce as part of my doctoral dissertation. And to answer your question, and I'm not sure when it was shown if you're seeing it very smoothly, because from my end, it's kind of, it's a bit, lagging, and maybe because of the technology, but I'm going to tweet later the link. So for those who want to see it again in a much smoother way, please. But also there's another film, because it's a two-part, my doctoral dissertation looked at into two communities. So you only saw, one. And the motivation really was, this idea when I was starting my doctoral dissertation, that my 200 pages will probably be read by only 3 people, and that's my doctoral committee. But these short 5-minute long films can be viewed by the world. And actually, as we speak, they've been viewed by tens of thousands of people not just in the Philippines, but also across the world. Before the pandemic, I actually showed this film and the other one in at least 20 universities across the world. And so I think one, there's really power in stories. Numbers numb, but stories stick. And stories speak to the heart. And I think we need to be better communicators if we really want to reimagine the future of health systems to become more socially and ecologically just. I think we're able to engage with broader audiences. If my dissertation can only be understood by maybe 10 people or 20 in my orbit, but the films really are able to spark a conversation, right? Like, why is climate change a pressing issue, right? It is already a reality in these communities, and that the health sector has a critical role to play in making sure that we protect and save lives in the era of a warming planet. So those are just some of my thoughts to your question. Thanks.
Thanks, Renzo. I've got plenty more questions to ask you, but I'm not going to hog the entire session.
Sure.
And for the attendees, remember to use the live Q&A part of the portal. You can type in your question there, and we can pose them to the presenters as we move along. Our next presentation is by Kriti Shukla from the People's Health Movement. Kriti, please go ahead.
Share my screen. Yep. So, sorry. Just a minute, something. My screen share. Are you able to see my screen?
Yes, we can.
Okay.
Just put it into slideshow mode. Yeah, perfect.
Yeah. So, hello everyone. My name is Kriti Shukla, and I'm associated with People's Health Movement. And I'm an occupational therapist with Masters in Disability Studies. My core area of work is disabilities and public health. Though I read and write, I always felt that information that we convey should be simple and should be very interesting. And more so, it is important for technical and policy related issues. So I sketch, and my cartoons focus on public health issues. And I use a little bit of humor and satire because I feel that it energizes people of any age, make people sit up and notice. So before showing like my illustrations, which I made as a part of PHM's WHO Watch program, I'll just run you through the small background of history of how illustrations actually came into being. So historically, if we see illustrations, we've been making from Paleolithic age, where humans used cave art as a means to express their feelings and emotions and ideas. And over time, it brought people to make drawings and illustrations. And we know these great artists from 17th century, Leonardo da Vinci and Lorenzo Bernini. They were the pioneers sort of to use caricatures to provide definite form and features to their subjects. But it was William Hogarth who developed pictorial satire, and which became precursor for development of political and editorial cartoons. So this is famous Gin Lane sketch made by Hogarth in 1751. And the sketch sort of shows two different societies, starkly different. One is Beer Street, one is Gin Lane. And the sketch was made to say that curb the consumption of spirits by raising the then very cheap cost of selling and buying gin. And here are a selection of public health cartoons from frequent cholera outbreaks that happened during Victorian era. And we can see this first cartoon is Death's Dispensary. This was a sketch drawn in 1866, and both were drawn in 1866, and they come in the time when John Snow was publishing his studies on cholera transmission, about the contaminated water supply. And yeah, and then you can see in this sketch, it's a political cartoon showing Board of Health defending New York City from cholera and using, new sanitation measures and even bottle of carbonic acid. And if we talk about social movements throughout history, intersection of art and activism has played a crucial role in, building up social movements, in portraying inequality and oppression and gathering people together. So during the times of HIV movements, we've seen that there were exorbitant prices of medicines and many people drew sketches around it. And this is the recent one, but similar ones were made, which had their impact on connecting larger group of people. Because it's an academic forum, evidence is important. And I found this interesting study where Taylor and Francis Journal found that articles which had cartoon abstracts generated more than 11,000 extra downloads for articles published in their journal. So we were interested in, the comic element, which comes as a complement or supplementary to the main article. We public health professionals, as we know that health, like any other issue, is deeply rooted in politics and policies. So when we say people's health in people's hand, we should make material, we should make our research studies as simple, as attractive for the communities for which they are intended, which is not the case many a times. So I sketch for People's Health Movement's Indian publications. And these are some of the publications which come out from PHM. Many other friends also contribute to it. These are just two of the sketches which I contributed, I'm showing here. So this first sketch is actually from is about a midday meal scheme. Midday meal is a nutrition program for children in India. And under this program, in few states in India, eggs were banned for kids to promote vegetarianism and some religious reasons. So I made a cartoon and satire on that. Then the second sketch is, portraying the problems faced by women who breastfeed at workplace and mostly unorganized sector, where there are no daycare facilities for children and mothers to actually feed their kids. So now comes the actual illustrations which I want to show you all. So I was part of World Health Assembly, 71st World Health Assembly, which is a WHO's assembly. Two assemblies happen. One is executive board and one is WHA, from which WHO puts the public health issues, they discuss public health issues around and policies around. So this first sketch I made was to support WHO, where we urged, these are member states around WHO, to support and protect WHO. I would say there is this timelessness in this sketch, because we saw how in pandemic, WHO was accused by a richer nation of being biased towards one nation and so on. So this illustrations hold so much meaning to communicate to member states that they should support and protect WHO. The second sketch is on social determinants of health. And this sort of is a commentary, or I would say draws an analogy that providing care without attending to social determinants of health is like mopping floor when tap is open somewhere else in the room. So then this one I drew on the topic of addressing global shortage of and access to medicines and vaccines. Now, access to medicine is a very geeky topic because it involves a lot of intellectual property right discussions, TRIPS discussions. So I wanted to make this concept, this multiple issues that we need to deal with to achieve access to medicines, wanted to make it a bit simpler. And I made the single picture to sort of tell the steps which are required by the nations to access the essential medicines. Similarly, I drew this cute snake, which during a WHO meeting, which was marked to pass a resolution to address burden of snake bites. And first time WHO included snake bites as in the list of neglected tropical diseases. So I wanted to make snake less scary and point out the need for more anti-venom. And so it's not necessary that every time it is going to be a very serious sketch, but it can be a bit humorous. This sketch comes at the time during the executive board meeting of WHO to end TB. And I wanted to point out the extension, WHO was extending the timelines to end TB. And we all know in certain nations where TB, like in India, TB is a massive public health issue, that how extending deadlines and timelines impact the public health. And also the second sketch was to sort of point out the issues around development of access to medicines for TB, mainly drug-resistant tuberculosis. So then I'll show some recent sketches which I made during the COVID. So in India, like in many countries, it is assumed that medical care is only done by doctors. So in this sketch, I made a busy scene of hospital to show and convey that medical care is a teamwork, where everyone from sanitation worker to administrative staff to lab technician to nurses to doctors, everyone puts their effort and is fighting the pandemic. So this sketch was widely shared in the start of the pandemic when PHM was working on issues faced by health workers. This sketch particularly comes in a very disturbing time because you all may know that in India, thousands of migrant laborers, pregnant women, children were walking hundreds of miles on foot to reach home because there was a sudden lockdown which was announced and there were no transportation services, and we witnessed gross apathy from government. So I made this sketch, and we all use this term social distancing, which is largely used everywhere now. And I wanted to emphasize through sketch that we need to change our words to communicate better. And yes, physical distancing is required, but you should not distance yourself socially from fellow human beings. So yes to physical distancing with social solidarity, and no to the term social distancing. So this sketch I published around at that time. Then this. So every month during the lockdown, our Prime Minister, there were these activities which were given during COVID to people, like clapping, banging utensils, or lighting diyas to sort of mark this cohesiveness that we are fighting COVID together. But during these activities, there were people in certain responsible positions who were saying that, burning candles and diyas in certain time, universe changes and temperature will increase and virus will die. So all sort of unscientific things were surfacing and rumors were surfacing. So I made this satire where people are discussing to put up scientific reasoning for an unscientific rumor. So yeah, that's the last one. So thank you. And all in all, I feel that illustrations are important, but they do not negate the value of academic writings. but it is important to simplify complex words and because it helps in shaping socio-political discourse and public health. And a simple cartoon transcends that barrier and helps in presenting complicated research findings in a simple way and helps in mobilizing as many people for the movement. So yeah, I'll wind up here if you have any questions.
Thank you, Kriti. That was wonderful, and really enjoyed having a third, fourth look at your lovely sketches. Yeah, I want to pick up on the last point you raised in terms of sketches being a way to communicate fairly, difficult concepts to people. But I suppose the other side is they are sometimes used, especially satirical ones, to exaggerate points, to the extreme. So I wonder, how do you balance that with, you're being tied to science and so on, or you wanting to keep it as ethical as possible? If you want to communicate those, exaggerated points, for example.
Okay. So yes, you're right that in sketches, to draw attention of the viewer, you exaggerate, let's say, a political figure in sort of face shapes, so that you instantly recognize that, okay, this is that person, without naming or telling that this is that person. But in terms of exaggerating the fact, the thing about comic cartoons and sketches is that you need to be well aware of the socio-political background to be able to understand that sketch. So let's say any sketch you won't find it amusing. You need to know the basics, like what is happening around. So in daily newspapers, you see there is an editorial. Unless you know what discussion was going on, you won't be able to catch that comic. So when I exaggerate certain fact, or not exaggerate, but when I use satire or humor in that, so usually I place my sketch with certain description, because not many people would know that what public health issue is happening, what is happening in WHO, if I just place some image out there. So what we do is we put description, we put sketch along with it. So one, it catches attention that what is this sketch about, and then people read the article. So it sort of is a very comprehensive way of communicating. Yeah, that's.
So, and again, just leading on from that, I think some of the more complex issues you've been grappling with, in your role with the People's Health Movement is, the role of certain actors, like the commercial determinants of health and so on. How easy it is? Do the sketches make it a bit easier for people to begin to grapple with those things in terms of power, its distribution, and developing more just systems? Over.
So yeah, like I don't have a sketch right now to just show as an example, but let's say I'll give you a background. When we talk about social determinants, when there's a woman working and two men are sitting and saying that she doesn't work, she just stays at home all day. That's a funny statement, but it just kicks you that, okay, this social aspect of gender, which is grossly neglected, comes out so beautifully in a sketch. And you need not say anything around it then. You're seeing that woman is working, she is doing all the household chores and two men are sitting, but for them, that's not work. So similarly in sketches, when social determinants are sort of complex topics, but it's fairly simpler when you make it attractive and humorous or satirical for people to read and follow. Yeah. So.
No, thanks very much. We'll pick that conversation at the end of the session. Yeah, but thanks for a wonderful presentation.
Thank you.
Our next presenter is Dr. Lindy van Niekerk, a PhD candidate at London School of Hygiene and Tropical Medicine. Lindy?
Hi, thank you, Kenneth. So today's presentation is actually on behalf of the Social Innovation and Health Initiative, for whom I've been kind of partnering with over the last 6 years now, conducting research, supporting the building of capacity in different research hubs across different universities in Malawi, Philippines, Uganda, and Colombia. And maybe back in 2014, so the Social Innovation Health Initiative has grown to a network of over 10 university partners and other international organizations, all passionate to promote the role of social innovation in health, specifically to promote for the purpose of universal health coverage as well as more just health systems. And right from the beginning, our focus was to conduct case study research on innovative models that we are seeing arising from communities, from non-traditional healthcare providers, but which has really made an impact in healthcare delivery in the country. And alongside the research, I think we very quickly realized that if we want to speak about innovation, we have to be innovative in our approaches as well. And film has become a real important pillar of the work that the Social Innovation Health Initiative has done. We've produced over 40 research case studies as well as 25 case films as a way to make the work come alive to people. A quote that always has spoken to us is the one by the African author Chimamanda Adichie, who says, "Stories matter. Many stories matter. Stories have been used to dispossess and malign, but stories can also be used to empower and humanize. Stories break the dignity of people, but stories can also repair the broken dignity." And I think within the current climate of the world, we've seen how often stories can cause really terrible effects, but also on the other side, the power of the stories that our communities can tell us that can really seek to repair the dignity, and also which our objective was to provide them a voice at the table. So the films that we've produced, the one that you'll see has been done with I filmed with the University of Malawi, at the College of Medicine, and we've been able to take these short little case films right into the offices where the people's voice would matter. And even if they can't be there, we take these stories. So whether it's to senior policymakers at the Ministry of Health, whether it's to meetings at the World Health Organization, and we've seen, as Renzo said, how it humanizes the policymakers or the decision makers in many ways, where it not only engages their heads, but very much their hearts. So the film that you'll see, I filmed it in 2018 in Malawi. It is an example of a community-led initiative, which has really supported this small community in a rural district to gain access to healthcare at a cost that they can afford. So Kenneth, if you could play the film, please.
Before a community-based health insurance, in most cases, people were suffering, they were dying with simple diseases because they were failing to assess the good quality of services at the health facility due to lack of money. These CHAM facilities are being found in very remote areas where people are very poor to get money. Kaundu Health Center is a CHAM facility being found in the remote area. It provides a lot of things which are being doing there. Although people are failing to get quality services due to that amount they were supposed to pay. So the Honorable Juliana Lunkosi has come with a suggestion to establish community-based health insurance.
We struggle a lot in the health sector. We look at the budget, the health budget, it's never enough. So I was tired of talking in Parliament about health insurance, so I said, let's just do it. I wrote the concept, went to CHAM, we have started it at a very small scale, but with plans to increase it. So here we are. It's always difficult to pay out of pocket when you're very sick. So they make monthly contribution, pay household. They put that money in the pool, then instead of possibly paying 2,000, somebody could be paying 200, and that they could afford. In that way, we can lessen the burden.
Banja latu lilotukuka chifukwa cha insurance imene tidalowayo. Atadwala womalizirayo amene timati Felix napita naye ku Kaundu ankatupa china chake uku. Titatero tidapita ku chipatala anandithandiza ndithu kopandanso nkhawa ina iliyonse. Kuchokera apo iyeyonso anandya umoyo waso pano ali bwino ndithu.
Our project is based in the communities, so it's the people in the communities being involved. If somebody wants to join the community-based health insurance, he or he is supposed to meet with the volunteers or the committee members in the village. So after being registered in the villages, they were supposed to pay 200 kwacha for the adult and 150 for the children. So all of these monies were being collected to the health facility. Then the health facility were the one who banked this amount of money. Kaundu Health Center has got only one nurse. We are failing to employ another nurse due to lack of money. But now, with this project, Kaundu Health Center has been employed now 2 nurses because of the community-based insurance. It's very different to other projects because it's the community members themselves which run this project.
You know, in Malawi, and just like any other country, you need bottom-up approach if we have to develop. We want to be pioneers of doing things differently within the health sector. Community health workers, when you use them properly, they can drive this agenda because they link with the community, and the community participation is great.
I feel proud because I assist my own people. I assist my own country. People are getting good medication, there is a decrease of deaths, so I feel very happy.
Thanks, Lindy. It's a lovely film and fantastic work that you're doing down there with your collaborators. So I'm going to ask a slightly, I don't know if it's a difficult question. You know, I've also studied CBHI in Kenya, and I mean, your film gave me pause for thought, and I was like, so why are we really worried about scaling up CBHI if it gives, you know, people dignity, if it's got embeddedness, ownership, it's responsive to the community? Are we trying to, you know, fit a square peg in a round hole?
Yeah, I think this example is especially, I mean, we've asked ourselves the same question, or especially the researchers who's working closer with this project in the University of Malawi. Malawi doesn't have a universal healthcare system in a sense of a national health insurance. And yet we are seeing this example of this deeply community embedded solution and where the community is running it. So I think for us, the idea necessarily wasn't the innovation as much as seeing how it's being implemented. It's run by the community health worker, which is the guy you saw in the video. The traditional leaders are involved in overseeing it. There's volunteers from the community as well as the health workers. So there's no corporate company sitting running the fund. It's very much them doing it. And the question is, do you leave it at that local scale where it is running well and people are owning it, or do you scale it up? And I almost want to maybe just counter the challenge of saying, I think we need to think differently about healthcare approaches, that not everything at scale will create greater effectiveness. But how do we rather empower more local communities, I think, to take ownership and develop these initiatives that in a fit for purpose way for their own contexts?
Yeah, I think the film is really powerful in bringing that out instead of, you know, a formal evaluation or publication and so on. And yeah, right, fantastic. We'll pick the conversation up at the end. I'll move on to our last presenter for the session, who is Sharad Prakash Chaturvedi, and he's presenting Reaching the Last Mile, Manju's story. So please go ahead, Sharad.
Yeah. Thanks, Kenneth, and good evening to all. Good evening from India. So, before starting the film, let me introduce a bit about the whole film and the idea where I am from. So, I work for CARE as an organization which is internationally known, and CARE is working in India since last 70 plus years. We have been into food and nutrition program for quite a very long time. And in India, we have been working in scale since independence. As an experience from from the nutrition and health sector, CARE brought in a very specific perspective of working with frontline health workers. So since the beginning of the large-scale programs, there is one which is very well known globally also, which is known as Integrated Child Health Scheme, which is largely for under 5 children and pregnant women, lactating women, to focus on nutrition aspects. So over there also, all public health interventions were targeted largely to the community through a frontline health worker who is actually from the community itself, and they are paid very minimal, but largely their focus is what has actual change maker actually. So in 2006, India's health program brought in a supplementary program to push on public health indicators where they were lacking since long, and the speed is needed to be increased. So they brought in this piece of known as ASHAs. ASHAs are frontline health workers, largely mostly, or I would say purposefully females from community, from the same village. They are actually, ASHA is a short form. They are known as accredited social health activists. So they are basically volunteers. They do public health interventions in community, largely around pregnancies, deliveries, and newborn care. And for achieving those outcomes, they get some kind of incentive from which they run their lives at home. So these women are from their communities also only. So this film is all about one of those ashas, and this project is in Bihar right now. So Bihar is one of the second largest state in population, and most dense state in India, because it accounts for 130 million as a population, and there are 100,000 frontline health workers like ashas who are working over here. So this film is about this one lady, and let's see the film and go ahead with the other narrations after that. Let me share the film.
तीसरा बेटी मेरी, जब यहाँ पे कोई गाड़ी का साधन नहीं था, मेरे सास नहीं थी, बहुत ज़्यादा ब्लीडिंग हुआ। ठेला पर यहाँ से फिर ले गया। रास्ते में मेरे बेटी का जन्म हो गया। चार घंटा जो पुरैन होता है अंदर ही रह गया। फिर ठंडा का महीना, एगो चादर पर। हम ही नहीं चाहते कि मेरा जैसा दुख किसी का और को हो। भूसौला में ज़्यादातर गरीब लोग हैं। पहले टीबी से लोग मरते थे, चेचक से मरते थे, काला जर से मरते थे, डायरिया से। हर मंथ में 2-4 को बच्चा डेट करता था। आज जब से आशा आया है दीदी, बहुत बदलाव हुआ है बिहार में। साड़ी हम लोग के मिला है, तो ये ऐसे ही साड़ी पहनती हैं। जे नीले है, आई नीले पार वाला। पैसे के लिए नहीं कर रहे हैं सर, काम ऐसा करें कि ना किसी को भला हो। रोज़ सुबह हम गिरीवेट के लिए जाते हैं, चल के करते हैं। हमको इतना लोग जान रहे हैं, हमारे हम किसी को बता रहे हैं तो उसको फायदा हो रहा है, तब ना मेरे पास आ रहा है। टीका लगेगा। हम लोग काम करना स्टार्ट किए सर, तो माता की मृत्यु भी कम हो गया, बच्चा के तो बहुत कम हो गया मृत्यु का। बिहार में अच्छे हो गए हैं।
Thank you so much, Shara. It's a beautiful video, and it's wonderful to learn about the work that you've been doing with the Ashas in Bihar State. I'm going to ask you a slightly unfair question because I'm aware that during the COVID pandemic period, the welfare of Ashas and other frontline workers has been quite topical. And I think there've been work stoppages and that kind of thing, in perhaps not in Bihar, but in various parts of the country. And I guess for you, I mean, on reflection, could we have been better prepared to make sure that our frontline workers were better protected and better, compensated for their efforts?
So, yeah, it's a difficult question to answer. But see, you can never be better prepared. You have to start somewhere, somehow. And we being working with frontline health workers, before Ashas, we were working with ICDS program, which is known globally also. So there also the Anganwadi workers face the similar kind of situation. But we have seen that these mothers have actually brought a change. So they are the mothers who have faced themselves those situations where they have lost their own children. They have seen children dying in their families during birth, after birth. They have seen maternal deaths happening within their families. So they come from that kind of background which they have learned. We do believe that they should be paid better, but the thing is, large part of India is rural, still rural, and the kind of facilities in the rural India, mostly they don't depend on these kind of jobs. So this it's not a job actually which Asha is doing. Asha, this is kind of a voluntary service where she also gets a benefit of faith, which she creates in the community, which she creates through her knowledge, through her participation in family, household level behavior change. And they are not only behavior, they are working on behavior change on public health front. So they are social activists largely. So every behavior have large underlying causes which are far more intense, which we as in public health experts, even in government system, we don't address. So they individually face gender issues while going to houses. They face gender issues at home. They feel they face the number of children to be fed at a family level. So they know what kind of food security they have. So in all those kind of situations, they know what they have. And as a public health experts, we encourage and we try to see them to take them to that kind of solution where they build that kind of confidence in community. We hope that the whole process of incentivization of this whole Asha as a service which she is voluntarily providing is just a means to get them to motivate them to do something for their own community. Beyond that, this incentive doesn't help a lot. Though in my personal thought, incentives actually harm public health programs. So if it is voluntary, it is more convincing, more participatory, more local solutions come out. So this is how this ASHA is also working. And see, this is one story of one ASHA. So there are 100,000 ASHAs in Bihar. They are catering to more than 2.7 million pregnant women every year. Almost 2.5 million births happen over here. And you have the story have shown a change where we have reduced maternal deaths. And this is about a state where we have very poor primary health structures. So the primary health structure where delivery happens largely counters to 2.5 it is like 200,000 population, a 6-bedded hospital to 200,000 population for like 300 to 600 deliveries seasonally, so every month. So that much, so large load of public health lies on the shoulders of ashas. So they're this whole um, experience of working with community and working with them, seeing them finding motivation in their work is something which is very important. And this film is actually dedicated for their good work, because we can't help them a lot in their incentives, but we can do help them to get that kind of recognition nationally, at state, to see their contributions. And we have seen this happening during this COVID times also. So in these pandemic times, the frontline workers, ashas, actually played a very, very important role when large population, and the state is high on migration. So from uh, most of the states, when immigrants was happening, immigration was happening. So these people were there standing on the gates of villages to actually enroll them, to check them, to counter them, and answer everything where the doctors are not available. So these are the women who have done that kind of job. So that's all this small film is all about, to just to motivate them, to acknowledge their hard work.
All right, thank you so much. A question for Lindy from Elena, which is related to the question I just asked. So Elena asks, can you say a bit about how the community health workers are funded and whether it comes from the CBHI funding pool?
Yeah, the community health workers in this example is they're all part of the Christian Health Medical Association. So certain for health facilities, especially in rural areas in Malawi, is covered through an agreement by government, but by the Christian Health Medical Association. So the community health workers and the health staff is employed by them. And then everyone else who volunteers specifically for the scheme is doing that on their own accord.
All right, thanks, Lindy. Kriti, there's a question for you from Leanne. So she says, great illustrations. And she says, your work really shows the important ways in which social activism intersects with the health system. And would like an example of the work you and the People's Health Movement have done where sketches have been used to support social change in the health system.
Thank you, Leanne. That's so humble of you that you liked my illustrations. I've been making these illustrations and sketches, and we use them in different forums. So when we go to, let's say, watching the World Health Assembly, there are live sessions which are happening, and we hand out policy briefs and notes to international delegates, the non-state actors there, to advocate that what exactly is the issue around. So we make these sketches, put the note, and send it out to people. Then we also, I just have few. So we make these small booklets. Now these booklets are for people, not public health people can use it, but we make several of these booklets. We translate them in different languages, so that, and we put a lot of sketches in that. Then we try to explain complex global public health issues and how they affect their health. Now so we would make, let's say, a conversation between two women. that how is, weaker health system going to affect me? So they are having conversations. So then we also made few comic graphics where we tried to tell what is the problem with the insurance model and how people who require care are not able to use it. So we use a lot of these illustrations to sort of connect with the community, to give this these information out creatively. We use it on Twitter, on Instagram, on our social media handles. So then people, I mean, we get more followers also, and people sort of, it clicks them that yes, there was something which we did, that image sticks in your head. So yeah, that's how we are doing it. So yearly, every time we publish, we make sure that we have a sketch and a cartoon to sort of simplify that complex topic. Yeah.
Thanks for that. That's really useful to know. And yeah, I know Brady is listening keenly. Renzo, you're involved in a number of things, including, decolonizing discourse and so on. And I wondered if you see a space for multimedia in that discourse, and particularly, revolving around, these concepts that you're also grappling with and that are related, decolonizing planetary health and global health and so on.
Right. Thanks, Kenneth, for actually raising the colonial theme, which I see really as part of this broader planetary health story that we're trying to rewrite, because as you know, and as maybe some of our listeners as well, planetary health acknowledges the many different forms of knowing. It's not anymore just the Western centric, scientific ivory tower kind of investigation and again conveying of the message. And I think while my films focus on climate and health, I think there is the colonial aspect to the use of the films. First, because of course, in my dissertation, I wrote about what I saw, what I observed, what I've gotten from the interviews, and then as a researcher, you massage them, you analyze them. But the films are very raw, right? Of course, that's captured by the film, and I have editors who help me, refine and weave the different clips. But really, you're hearing the voices of the interviewees themselves. They're not being interpreted in another medium, such as the written dissertation. And so films are actually not just powerful in terms of documenting these different forms of injustices, but also in creating new spaces for conversations, for really capturing the voices of the people themselves. If you notice also, I was not even narrating in these short films. It's really the people, and my role was really just to weave the stories and to translate in English so that you can understand some of the Filipino terms and sentences that were uttered. So yes, and I think this is going to be the new era of research and education in global health, in health policy and systems research, in planetary health. Are we ready to consider films, documentaries as academic work, in addition to what's written, to what's published in the journal? And it will require some really, bold decisions and openness. For instance, in the academic world, I think in the world of practice, we're starting to use more and more of these new media. But in academia, I would love, for instance, to see PhD dissertations, not in written form, but in audiovisual form, and that they're even co-created with the communities themselves, right? Because the communities may not be able to contribute in the writing, although I'm pretty sure there are also other interesting examples of that happening. But the films and theater and poetry and music, you know, can be co-designed, co-created, co-produced with the communities that we, you know, quote unquote study, you know, and that makes them less of guinea pigs, but more of partners in the generation of knowledge. Thanks.
No, thanks, Renzo. As in some food for thought for, you know, those of us in this space and bridging the space between academia and practice and so on. Sharad, Elena has a question for you, and she thought your film was absolutely beautiful, and wanted to know who you worked with to produce it, and what challenges or constraints you experienced in what to include in the final film.
Oh, great. So the first question first. So this product was developed as an there were other products also. So we, as in Care USA, Care India, and there was this Blue State Digital, which is US based our company. We came together to develop this media piece, and there were other media pieces also. They helped us to capture the story the way we wanted to be captured. They helped us in editing, shooting, a whole lot of things in production basically. So the whole idea was to get a brilliant short story to tell the global audience about the importance of frontline health workers and our belief in them to actually bring all necessary changes in human lives at large, at scale. So they are the only people who can actually bring change. That's what the belief which we wanted to turn into. It was quite difficult to capture everything because there was so much, and this is not only Manju. We shot about 2-3 Manjus type of Ashas, and we got one Manju story to be released and made this piece to create and connect between the problem which they faced and the larger public health problems which we are in, and how they conquered it in their real life, and how we are actually discovering the change in scale. So this whole combination of showing their role in believing and changing the community lives is something which was done largely, and we think we did a fair job with Manju, and we know that Manju herself is very happy to see this film. When we screened it in her program area, her project area, with many Manjus coming together and seeing, and they were all asking, why don't you create a film for us like this? So there are Manjus, and they are really very happy to see this. Hope we have contributed and did a fair job with them. That's it. Thank you.
No, thank you. It's a fantastic story and a fantastic set of pieces. As with Renzo, we didn't manage to show all the wonderful pieces you submitted, but yeah, there is quite a lot, and you could share that with the people, I guess, on social media, or using tagging the HSR 2020. I think that would be a powerful way of getting that out. I do have a question for Lindy, and I think this is related to what Sharad mentioned in terms of and Renzo, so in terms of translating it and working with local languages and so on, but also bridging practice and evaluation. So you've got this scheme that is being evaluated. Is some of the media products you developed, or the multimedia products you developed, are they being analyzed for content analysis as part of the evaluation and so on? Over.
So the way we've been doing it is that we've done the research and the filming process almost in parallel the whole time. So the local country team of researchers, which would be in Malawi, they would go out to the different social innovations identified and really do a more thorough, in-depth studying of that. And then on the side, we do the filming too, and we want to, of course, let some of the themes and some of the things come through in the film, or at least bring the research to life. So we haven't per se go back and reanalyzed the film content, but we very much collect them in parallel as two different mediums.
All right, great. So there aren't any more questions on the Q&A chat, and it is a little past 7 in my part of the world, and I know getting very late in Sharad's and Kriti's part of the world. So I want to bring this wonderful session to a close and thank all the panelists and all those who attended and those who've been offering support to the session in the background. That's why everything has been running very smoothly.
Yeah.
And wish you a lovely remaining part of 2021. It's never too late to say Happy New Year. Never.
Happy New Year.
All right.
New Year. Thank you. Thanks.
All right. So take care, everyone.
Bye,
and,
everyone.
Thank you.
Good
bye.
evening.